But we are very specifically wanting to look at conflicts that aren't so much covered today. And in fact, if you look at a very useful report that comes out from Norway, talks about what are the most neglected conflicts. And the list there had them actually all in Africa, a very long list. And 2 of the countries are represented here, Sudan and Cameroon. And we're very, very well aware that Myanmar are facing difficult times, and particularly our healthcare workers have been at the forefront of some of that. And so we're absolutely delighted that Wawa is joining us today. We've pre-recorded these sessions so that we don't lose it if the internet is difficult. But I want to just move straight away and take the person from the top. And Dr. Nahla is actually a very dear friend of mine. Delighted to welcome you here. Nahla is the lead at the Khartoum Cancer Center, RIC. She's also a consultant with EMRO, WHO at the moment, and she's been the lead for palliative care in Sudan for some time. She brings to us a whole lot of expertise in developing programs in Sudan, but also has finished her master's and embarked on her PhD at King's College University. So Nahla, you're very, very welcome. And we'll now hear from you, and then we'll have an opportunity for questions. And mostly after Nahla has spoken. While we're listening, please, please, please write your questions and your comments in the chat, and we can have a very interactive session. Thank you so much.
Thank you so much, Moira. Wonderful to be with you. Thanks, PallCHASE, for this invitation. I'm honored to be part of this work. And I am very happy that you are now reflecting on these hidden conflicts and hidden forgotten people. Thank you so much. I'll be reflecting about the situation from Sudan. We are a unique country in that we have had almost 17 military coups, the largest number in Africa. We also have vast borders with 7 neighboring countries. So who are these people in humanitarian crisis? These are the refugees from nearby countries due to war or political instability. They are the asylum seekers. They are the internally displaced. They are the victims of conflict and natural disaster. The refugees in my country form about 1.1 million people, and they are coming to Sudan mainly from Chad, Eritrea, South Sudan, and Central Africa. The majority of them leave the camps, and they live in the outskirts of the main cities. The situation in the outskirts do not meet the minimum standards. The internally displaced is another group, almost 2.5 million. They are in the far west and in the new borders with South Sudan and in the southeast. And people in these yellow states need 52% of the people in the states shown in yellow are in need of humanitarian assistance. Natural disasters like flooding and fires. In Sudan, we have flooding almost every year, especially around the banks of the Nile, leaving thousands of people without shelter and without their belongings. And the photo down about the fire, this was taken yesterday in the outskirts of Haj Yusuf in Khartoum. I had a personal experience with flooding when my friend's family in 2013 were totally, the whole area was totally surrounded by water, and it was stinky water, and nobody could enter there for 7 days. We managed to arrive to them after the water went down a little, and to reach them, we had to step on the broken and fallen houses. And I remember the psychological shock that this family had. So these people have got varying needs. The internally displaced, according to the relief organizations working in the area, they mentioned that the priority of the internally displaced are livelihoods, education, and shelter. while the refugees mentioned that shelter is their main need. For people living in the camps, it is livelihood, health, shelter, education, and water in that order. So what are the challenges affecting them in order to access health services, including palliative care? We have to understand that these people are coming from different social, cultural, and linguistic backgrounds from the people they are surrounded by. And that makes it more difficult for them to access the services. They need to travel to the health services because we have few oncology and palliative care services in the country. And these people are financially challenged. They travel for days from their original places. And all that leads to their late presentation. We also have to tackle the problem of identification because they have lost they don't have an ID or they don't have a documentation, or even if they have a card mentioning that they are refugees or what you call it, nationals of another country. In the hospital, unfortunately, they are treated as foreigners and they pay the full price of the medicines and the service. I have three cases to show. The first patient is a young man from Eritrea, and he was in the refugee camps in the east of Sudan. And he presented with us with a poor general condition and a huge abdominal mass. The investigations showed that he has renal cell carcinoma with lung mets. And so I had to go into the discussion about his diagnosis and his prognosis and where would he like to stay, considering the short lifespan he's going to have. And I made use of the relative who knows his language and my language. And after going into the middle of the chat and describing to him and explaining to him his prognosis, the relative confessed, doctor, I didn't say that. And what were you saying? And he said, no, I was just reassuring him all the time. So I had to go back and use another use another translator to help me for translating to this patient. And I checked with that translator that he translates what I want step by step and not say what he wants. For this patient, we supplied him with 2 months supply of morphine, and he went back to his wife and children. The second patient I have seen a few days ago. This is an elderly lady with advanced stage cancer, and her symptoms have been controlled. So for us, it's better that she stays in her house or near where she wants to stay. And so I asked her, would you like to stay here in Khartoum, or would you like to go back and stay in your family house and like this? And she says, yes, I want to go back and stay in my house in the outskirts of Niala. And then her daughter whispered to me that the house is not there anymore because the whole village has been set on fire. And this is a big challenge for us, for these patients also. The third story is a lady who had breast cancer, and she's coming from Congo, and she had the surgery in another country, and because of the war and the unstable situation, she arrived to us after 1 year from the surgery. Her treatment was compromised because, number one, she didn't do the correct surgery. The axillary clearance was not done. She didn't pursue the adjuvant chemotherapy in time. And so she came with us with a 5 centimeter axillary unresectable mass. We see a lot of patients like this with huge tumors. This was yesterday. This patient, also a refugee, presented with this huge mass with foul smelling odor. And we did the dressing. And before doing the dressing, we gave her morphine because of the pain. And we had this thin sheet of flagyl over the wound and a thin sheet of gauze so that we allow aeration. So when we are dealing with these patients, you can see that this patient's arm on the left, she's very thin. In fact, this patient had a hemoglobin of 4 grams. This is the lowest hemoglobin I have seen in a patient in my life. 4 grams per deciliter. And her teeth were almost all gone. So when we are dealing with these patients, we have to remember the trauma that they had undergone, psychological trauma, and they might be a lot of losses, not only in belongings, but in the dear lives of the people whom they love. They have their basic needs unmet, like the need for food, water. They need financial assistance. They need help in order to navigate the complicated systems that we are having in the hospitals. And they come to us like the lady we have just seen with poor nutritional status. They have neglected their comorbidities. They are not managing their diabetes, their hypertension. And most importantly, they need a place of care because home is there no more. Thank you.
Thank you so much, Nala. That was incredibly moving, but also just painted a picture for us of how things are. And thank you also for reminding us of the internally displaced as well as the refugee population. Is there any comments you want to make additional to your film just now? Or are you happy for us to move on?
I think no other comments, but I'm ready to answer the questions of, I think some people put something on the chat.
So that's a good point. So thank you. Yeah. We'll take the questions a bit later.
About, are we following? Okay, yes, that will be better.
Yeah, lovely, lovely. So Nala has reminded us, you can put your questions in whenever you want. We'll keep a hold of them and then the panel will bring them together. But thank you, Nala, for a wonderful start. Now, I think on our list, I'm just trying to order a place. Just joining, please tell us who you are. Put something in the chat so we know who you are. Invited now. Welcome, Eric and Z. Now, Eric, I've had the privilege of knowing you earlier in your career. Rita, I wonder if you could mute. Thank you. Earlier in your career as a palliative care nurse, when you were doing your bachelor's, you were the lead at the Cameroon Baptist Convention Health Service for palliative care, which is the leading service in Cameroon. And you have not only completed that training, but you are now doing a master's in Uganda. And you have a particular love for reaching the most neglected and for training. And you gave me a wonderful quote, which talked about your faith, your Christian faith, being at the heart of the compassion that you bring to palliative care. So, Eric, welcome, and we look forward to your session, to your talk now.
Thanks for about palliative care, and we are going to look at the experience of palliative care in Cameroon. Palliative care in Cameroon started as far back as 2006, and this was by a faith-based organization, the Cameroon Baptist Convention Health Services, at the time when HIV and AIDS was at its peak and many were suffering. In our country, in the little areas where it exists, we have the mixed models. We have the hospital base, we have the outpatients, we do home visits. And so it's just a mix of all of that. It started in Bansot Baptist Hospital and has moved to some of the major hospitals of the Cameroon Baptist Convention. And the government health services are also getting involved gradually. So far, we have trained over 2,000 healthcare workers and many community volunteers so that they can help us in the fight. In 2009, it was the time for the formation of the Hospice and Palliative Care Association of Cameroon, so that it can pioneer activities of palliative care in Cameroon. Unfortunately, this organization has actually gone to sleep for quite some time. But then, what is palliative care to us in Cameroon? Palliative care is care for those with serious health-related concerns, and especially to those at end of life. And for us, it is all about holistic care. It is about being there for the patients and their families. It is about taking care of their pain, doing the dressing change. It is about giving the nutritional support. These are the things that are embodied in palliative care as we offer in Cameroon. It is also about doing something useful for your patient, communicating well, and relieving them of their suffering. It is about care to the adults as well as care to the young ones, because each life truly matters. It is about care to those in crisis, those in war-torn areas, like has been the case in the recent years. So far, I am just indicating a map which shows the services that are available in Cameroon. If you look at it keenly, you realize that it is in the northwest and southwest part of the country where we have the bulk of the services. And unfortunately, this is the area that has been plagued by the ongoing socio-political crisis that has brought untold suffering to Cameroonians. This suffering started far back in 2016. It was simply a peaceful protest, but unfortunately, it escalated into a political crisis that has led to severe suffering, displacement, and lots of people with increasing palliative care needs. The effects of the crisis on palliative care are enormous. It has brought about a lot of financial hardship. It has brought about a lot of financial hardship and trauma, physical, psychological, to all who are involved. Initially, we were doing home visits when we started palliative care, but this has truly limited our efforts, and most patients are suffering when they cannot even reach the hospitals. We have a lot of ghost town days and people cannot move around. There has been an increase in the number of refugees running to Nigeria, coming around, and the internally displaced people. Morphine has also been a real issue. This is our major drug that we use for pain control, but the government policies are not really supporting, and especially in the advent of the crisis, they think that the drug will be misused. So the drug has been in so limited supply and equally inaccessible to many, and most patients are suffering. The hardship has been compounded by the coming of the COVID-19 crisis, which has brought about lots of suffering to personnel and even the healthcare facilities that are unable to cope. We're also noticing diminished or even absence of the international support that we had. I remember in 2017, the international team from Hospice Africa, Uganda came to Cameroon, but they were not able to visit the facilities because of the crisis. When Mercy ships arrived Cameroon in 2017, the intentions were also to go beyond, but they ended up just being around the coastal area because the crisis could not allow them. Doctors Without Borders, who have also been useful within the period, their duties have been terminated by the state because the state thinks more that they are conniving or working together with the terrorists. And so this is bringing about untold suffering to the patients that we have. I just wanted us to look at this keenly to see that in 2015, 2016, we had lots of home visits, above 1,600 home visits in a year. But when it comes to 2020, 2021, we realize that this number has dropped almost below half. Now we have around 600 patients. This is telling us that our work is actually going down. Even the patients we were seeing at the hospitals has actually dropped so significantly. But this is not because the patients are not there. There are more patients who cannot truly have this care just because of the crisis. What strategies have we then used during this difficult time? Yes, we have truly reduced home visits to minimal because it is not safe for health workers to get into the homes. I remember one of our workers was shot dead during a home visit and many others injured. So because of this, we have limited to doing just the minimal. And also, we have decided to get onto optimal use of the electronic platforms using WhatsApp, mobile phone consultations, continuous psychological support on phone. We're doing free online consultations. We're equally doing Zoom meetings with our staff because they're staff in areas that we cannot truly move to empower them as was the case before. Yes, palliative care is all about integrating services, and we are doing this more to just ensure that those who even go out for other services carry along a package of palliative care so that we can be able to meet needs of patients. For instance, those going out for screening for HIV also carry along the message of palliative care so that patients can actually benefit. We are also using the church approach because through the church, we are able to reach more people. So through our churches, we are reaching the people. We can easily meet them at the church and we can give them the support that they need. Also, knowing that doing nothing is not an option, we resorted to doing our local fundraising to see that even with the little resources that we can get, we can be able to help our patients. And that is when we brought in the strategy we call the 1,000 project. 1,000 in Cameroon is equivalent to $2. We are saying that you can use $2. The person giving gives without feeling pain, and it relieves the pain of someone who has palliative care needs. This is because lots of people have palliative care needs. There is no health insurance in Cameroon, and their suffering is enormous. But when we are able to even donate and sacrifice the little we are giving, it can help them a lot. This fund is helping our patients buy them pain medication, get material for dressings, and also sometimes support them with food and transport because you give medications and there is no food for the patient. So it's a small strategy and it has helped us a lot. If we look at the little statistics there, we realize that the donors have increased what has been given over the years. It keeps increasing. It looks small though, but it's making a lot of impact. Next slide. You look at it keenly, you realize that many, many people have actually benefited from this service. Cumulatively, we have over 756 people who have been assisted even by this little fund. We realize that if we continue to put hands together, we can do a lot for the patients that equally come our way. Next slide. So we are saying that there is great need for us, especially in humanitarian situations like what we find ourselves in Cameroon, to have the government involved so that our patients can benefit more. We are also intending that the international community, looking at what is happening in Cameroon and the challenges, should also be able to partner with us so that we can support those who are truly desperate and suffering. We are saying that if we continue to integrate palliative care at all levels and having it as part of our healthcare system, a lot will be done. If we look at the situation in Cameroon, palliative care is not part of the training for health workers, nurses, and doctors. But if the government, if the policy makers should put this in place, it will go a long way to help that those who have been trained in the various training schools, when they come out, they will be able to give holistic care to patients who need it because the burden is truly huge. Thank you so much.
Thank you so much, Eric. And I just want to let everybody know that Eric and Erin, I think it was 4 attempts because of the challenges with weather and with internet to get that fantastic 10-minute talk. Thank you for that. And you brought in another issue, really, access to morphine is there in the questions. I'm sure we'll be discussing this. And also some very local solutions to what is a huge problem. Thank you so much for that. Our final speaker, I'm delighted to introduce Dr. Wawa Mintsu. We've met just a couple of times, and we're about to do some partnership in Myanmar, but things changed. And we're so delighted you can join us today. You're a radiation oncologist, as Nala is, in a different setting. I see you also have the same link through Ask IDEA program. But you're coming to us from your role in Yangon General Hospital, and you have a couple of other hospitals that you're offering oncology services to. And you're also the lead for palliative care. And you've been setting up palliative care over several years. And I note too, you've also got a role as a mentor in a WHO program run from St. Christopher's Hospital, St. Christopher's Hospice, and in Kerala. So Wawa, over to you.
Good morning, good afternoon, and good evening. First of all, I would like to thank the organizing company of the PallCHASE Webinar for allowing me to present challenges and barriers of Myanmar palliative care journey. I'm Dr. Wawa Mintsu. I'm radiation oncologist and palliative care clinician from Myanmar. In Myanmar, our total population is 54 million. However, the number of oncologists in the full country is less than 100, and there is no full-time palliative care clinician in the country. So for me, I'm radiation oncologist and doing the double workload to practice palliative care. The level of palliative care is 3A. That means that we give isolated palliative care provision. And however, the rates of adults in need of palliative care in our country is 69 to 145 per 100,000, and the rates of adults in need of palliative care in end-of-life care is 234 to 353 per 100,000, and the morphine equivalent is less than 0.01 milligram per capita. So these data show that how much we need palliative care. This is the number of patients attending the palliative care OPD from the start of our palliative care service in 2015 August to the 2022. So we all know that cancer has not only the physical burden, it has a multidimensional burden, and our palliative care is for caring of that vulnerable people to give the value-added compassionate-based palliative care. So in addition to the cancer patient, during the pandemic time, COVID is a big issue to every people in the world. So during the pandemic wave, although palliative care is very new in our country, we participated in the COVID management in the hospital and also in the COVID center. So the availability and accessibility of the pain medication and essential medicine for palliative care is vital to the palliative care service. In our country, for the pain medication, there is a government FOC supply of pain medication like codeine, tramadol, and morphine. Although it is an irregular supply or inadequate, it is very and or sometimes the patient has to use out of pocket to buy those medication, and sometimes there will be the donors who are donated to come and donate for the medication. So our palliative care group is we have as a social support program. We find the donors so that they donate the expensive pain medication or for those patients who are very poor to buy their medication for themselves. So, and for the holistic approach of palliative care, we need the psychosocial care and the spiritual care approach. So during the COVID time, with the help of the Batoma Cancer and COVID-19 support group, we have done online service and also the online training program to the volunteers. And also the spiritual health talks, how to deal with that difficult time, challenging time. And as a self-care program, we also arrange the online Zumba and yoga, and for the healthcare professional and to our volunteers, and also for the cancer patient, with the help of the art therapist, we arrange expressive art therapy, both face-to-face and online program. So this is for implementation of this holistic approach, education is very important. So for that education, since 2017, we did have a stakeholders meeting to integrate the palliative care in the undergraduate medical and nursing curriculum. Due to that policy and the hard work of the palliative care, our palliative care can be included into the integrated curriculum for the undergraduate medical education for 30 hours in year 4. So in addition to the curricular involvement, we also aim towards the trainings program. So with the help of the APASIAN from 2013 to 2019, 29 healthcare professionals, and among them 17 professionals are trained in the clinical attachment program. However, very limited people can practice palliative care due to the no career ladder and the no organization setup, and also they are moved to the other department, so that very limited people are practicing palliative care. So now I encourage the junior colleagues and those who are interested in palliative care from both government and the non-government or non-government area to attend the online fellowship program from the Institute of Palliative Medicine, Kerala, India, and St. Christopher Hospice. And also, with the help of that online CME phone apps, we have a very good opportunity to share the essence of palliative care through that phone apps. So in the challenging time, and to overcome these challenges and to develop the palliative care in our country, we need leadership skill. So I'm very glad to be chosen by the American Society of Clinical Oncology to attend the Asia Pacific Leadership Development Program for 1 year. So the program is completed now, and we hope to implement our HOPE project. So these are some of the organizations we are working, helping us to support our service development, policy development, education development, and availability of the and donation of our medication and equipment. And for the public participation, we celebrated the World Hospice Palliative Care Day at the Ulachong Hospice Cancer Foundation as a collaborated event. At this year, we launched the HOPE project, helping oncology patients and families at their annual life. Sorry, and this is the door gift we distributed during the events. And however, to have a sustainable development of the palliative care throughout the country, and we have a lot of challenges and barriers, like the barriers from the healthcare system, the barriers in the healthcare professional and healthcare system and healthcare professional, barriers in the patient and family, barriers in the treatment method, and barriers in the culture issue, ritual issue, and also a political issue. So to face that challenges and barriers, we have many conflicts. So there are different types of conflicts. And while we are searching the literature, we can find there are some strategies to overcome this conflict, like we have to accept the conflict and accept the responsibility, and we have to work together and to analyze that conflict, etc. So I think to overcome these challenges and barriers, we have to analyze our circle of control and circle of influence and circle of concern. And also we need to analyze the SWOT analysis, like we have to analyze what are our strength point, weak point, opportunity, and threaten point, and also a past analysis of past, like the political, economical, social, technology, environment, and legal. So to develop palliative care in a resource-limited country, we need a community participation, and we need stakeholder supports with the compassionate actions, and we have to nurture ourselves to develop the resilience. So let me conclude my presentation with a famous or words from the movie of Everything, Everywhere, All at Once. So I think that we all know about that movie now. It got many awards from the Movie Association. And from that movie, it is said that be kind when you don't know what is going on. So thank you so much.
Thank you so much. That was amazing, Waba. Thank you for giving us an overview of palliative care in your country and then of how things came in. But I love the way you brought in those leadership tools, really, to think of your situation and to focus on what can be done, rather than, I suspect at times you can be overwhelmed with what can't be done. But thank you so much for that and some very practical ways that you have been able to connect. We're going to move into our discussion now. We've got some questions. Please add your questions. I can see some lovely positive feedback for those who are, so please read your feedback, speakers. People are saying lovely things, and quite rightly, because those were three fantastic, very, very carefully put together and compassionate sessions. In our panel, we add Dr. Megan Doherty, who some of you have met at the beginning, who's a pediatric palliative care specialist from Canada and has worked in many different settings in humanitarian palliative care. And we're delighted to have, for the first time, Dr. Thin, who is joining us. She's actually a chemical pathologist and metabolic medicine doctor. She's from Myanmar and had been involved in partnerships for Myanmar previously, and from 2017 was the lead for the Tropical Health Education Programme, which is all about partnerships and development and linking together. Thank you for coming and joining us and bringing that development expertise. I see too you have founded at least 2 charities linked to Myanmar, and I think that's something we're seeing from all of the colleagues here. So we're delighted to have you. We'll go back to the main screen. Thank you, Megan. And we've got to say a number of questions. I wonder if we could just take something just very practical. First of all, there's an issue of oral morphine. I'm hearing it definitely for Cameroon and for Sudan. And Catherine Pettis is on the call. And of course, this is her bread and butter is looking at access and issues around oral morphine. Nahla, I think there was a question sorry, there was a question, Eric, about access to oral morphine, and Catherine, I think you asked the same question. So, and Wawa, you may want to come in. So who would like to just address this issue of oral morphine? And then after a couple of practical questions like that, Dr. Thin, we'll ask you to make some comments as well before we carry on with more questions.
Yes, I would like to mention that having oral morphine is a prerequisite to providing palliative care. We cannot provide palliative care in any place without having oral morphine. And that is a drug for severe pain. And unfortunately, in Sudan, we have only 3 places where we have oral morphine. It is where the oncology and palliative care units have been established in 3 cities, 3 hospitals. And so for the patients who need morphine, displaced patients coming from the camps, first of all, they have to reach us. That is a prerequisite. I am glad that a lot of UNHCR agencies, they bring the patients, they cover the expenses for transport for them to reach the oncology centers, they pay for the medications. The morphine in the hospital is given for free, that is good. But the supply is not constant. Currently, we have a shortage of morphine. So in the palliative care unit, we developed a network. And so we are trying to see where the morphine can be available. For example, is some stock with some patient, because we usually provide morphine for the patient for 1 month. And so we can move around the morphine for patients in severe pain. We have been managing for some time, but advocacy is so much needed. We do the advocacy at all levels, at the stores, medical stores and supplies. It's very important for them to report the need to request the morphine. At the hospital administration, these days I'm sending my patients to the director and to the medical director, and they stay in the office there till they get their supply of morphine. For patients who are traveling for long distances, especially for such patients living in Eritrea, we also think about how to provide them with a good supply, at least for 2 months. And we keep contact with the family to come and refill.
Okay. Thank you so much, Nahla. What I'm hearing there is an incredibly creative approach to trying to make sure people have morphine. And of course, we heard that from Eric. You've been doing that in a really, really practical way with this. Remind me the name of this program that you started. It was something about, we're not in pain to give a donation so that other people are not in pain as a result of the donation. I thought that was a really beautiful way of encapsulating how donors can be involved. Do Eric or Wawa want to say anything about this issue of access to morphine?
Yes, Mara. Sorry about my voice. The morphine is a very difficult issue in our country because we are lack of morphine, especially oral morphine, for more than 30 years. So to have available of morphine, we palliative care group and the Myanmar Study of Society group is advocated a lot, and it is permitted from the Ministry of Health to manufacture from our own government factory in 2017. So for 30 years, it is no morphine. So after 2017, we started to use oral morphine, which is intermediate type, because it is the very first time. So we encourage the factory to start to produce intermediate type 1 at the tablet form and the syrup form. But it is, the stock is always out. It is irregularly supplied. And especially it cannot buy at the private hospital and outside pharmaceutical shop. It is only available at the government sector. And it is irregular supply. It is very limited supply. And we can only give just a few duration, just 1 or 2 weeks. So the patients have to come back frequently for the availability of the morphine. So as we have very limited stock, we have to think a lot how to give, how to distribute, which patient has to, we can give to those which type of patient. So we cannot use, we have to depend more on the codeine and tramadol, which can be supplied and which is not very expensive, and which can also buy at the private hospital. But for morphine, it is only available at the government and very limited amount. So at that time, we have to use fentanyl, because at first it is available in the private hospital and it is, the price is quite okay. But nowadays, the stock is out again. So our pain management and palliative care depends upon which type of medication is available now and which we can give freely, or what is the socio-economic status, logistic issue of our patients. So it is very challenging for us.
Okay. Thank you, Wawa. Eric, anything you want to add to that? If not, I would like actually to Eric, you mentioned about home visits being difficult. And I think one of our participants, Pranab, was thinking you meant home visits weren't important. But I think what I heard you say was that it's just physically almost impossible in the middle of a civil war. And so you're having to use other ways to support people at home. And I think I saw you're using some innovative ways and technological ways. Would you like to just comment on that issue of trying to support people at home when it may be difficult to physically visit the home, Eric?
Thank you very much, Dr. Moira and the team. Let me begin with issues around morphine. It has really been a challenge in Cameroon. Before 2016, our organization had the license to import powder morphine, reconstitute, and use for our patients. But with the crisis, the government has refused to give us that authorization. So this has really been very challenging for us. Instead of getting the powder to reconstitute and use for a patient, which was actually very accessible, cheap, and good for our patients, today we go in for this. This is what we are getting. The prepared form comes in 100 mils, and it's truly very expensive. This alone is like $5. And this is morphine, 10 milligrams per 5 mils, 100 mils at $5 to patients who do not have the means. It's a real challenge. We can easily get this, but unfortunately, our organizations are also looking at they want more things that can easily generate income for the organizations, and palliative care is not such a place that generates income. So less attention is being paid to this, and patients are truly suffering. I'm happy we have this opportunity where we have people who can support us, even import this for our patients. This will be very, very useful. We can have the contact and see how to go along. Also, talking about home visits. Yes, there is nothing that can replace home visits as far as palliative care is concerned, because that is when you actualize the situation of your patients and you can give them care in a much more better way. But we are saying that with the crisis, with the fact that some of the workers are killed in the field, this has actually reduced the home visits that we make. We are not happy that we are not seeing our patients that much, but we have decided to reduce this. We have chosen somewhat community participation involving home-based or community volunteers, involving the churches, so that we can reach our people through that. Our organization is not also supporting so much. Like before, we'll have a vehicle that takes us for home visits. But today we go on motorbikes, call it border border, as is in Uganda, to meet the patients. And it's not always safety, yes, but we are also concerned about our patients. And most of the patients don't even there with their problems, and they cannot even approach the hospitals. Unlike before that we will know the patients are there. Today we don't even know the patients are there. They're dying in pain and they don't have a means of coming to the hospital. We're just looking at opportunities. If we have more, we can begin to get into the communities as the civil war is reducing somehow. Fish out these patients and see how we can give them the maximum care that we can. Thank you.
Thank you very much, Eric. We just start sensing some of the challenges that are facing you there. Maybe to change on to the radiation oncology, David Fearon asked some time ago, I think directed at you, Nala, just what do you think about these internally displaced people that may want to move back to their home places, and what's the role of, always asking a very specific question, of radiotherapy in that setting?
Yes, the major challenge for these displaced and refugee people is to reach the health services, to reach the oncology services. Once they reach, I think we are always giving them priorities, by the way. We are always thinking of these people who, and also because of their the regimes that they are going to therapy, it's not going to be a prolonged course of radiotherapy. When we are speaking about a palliative course of radiotherapy, it's only, like, say, 5 fractions or 10 fractions, or even sometimes 1 fraction for bone metastasis, for brain metastasis, and the role radiotherapy is very important. I had a patient radiotherapy to the brain. He had a glioblastoma multiforme, and we spoke carer how to take care of this person by telephone and WhatsApp a lot to follow patients reach in Khartoum. So radiotherapy is very important for these patients, and the problem is that how they can reach us, the first point. But once they reach us in the hospitals, we give them priority. And I would like to mention also, our radiotherapy machines are not always functioning, and even the people in line, so sometimes we have problems of radiotherapy. We have only 3 centers providing radiotherapy for the whole country. And only one machine is providing 3-dimensional radiotherapy.
Okay.
Thank you.
Thank you. Thanks, Nala. And Wawa, this is a very challenging question in a way, but Father Rick has asked us to think about, or ask if you could comment on practicing palliative care in the context where there's a lot of grief and loss going on, both for the healthcare providers as well as the population. Could you just make any comments you would like to on that issue, Wawa?
Can you ask a question back? Sorry.
My apologies. The question was about grief and loss. You know, in the context of palliative care, we deal with grief and loss, but that is particularly challenging when there's overwhelming grief and loss in the population. I know I've seen this in different settings I've worked in. So any comments on just how we address those issues where healthcare workers are experiencing grief and loss, the population is experiencing grief and loss, and then you also have the palliative care patients to care for?
Thanks, Moira. Actually, this is the question I would like to ask to Nala, because I found out that she is dealing with a lot of humanitarian crisis too. Loss, for my concept, I think loss and grief issue is the most important, not only the patients, but also to everyone. So what I found out in this journey, or in the NALA presentation, I found out that, and in the COVID time, we found out there's a great loss in not only our health and life, but also our identity, our hopes, etc. So we lost in way of different many things, and if the loss is not really, we cannot manage very well in this challenging time. So in that case, we foresee that there will be the complicated grief issue we can face in near future. So I think for me, I think the essence of palliative care is that we are advocating and we are promoting the awareness of the loss and grief issue. So I think it is in every level of, it is all around the world. We can see a lot of loss and grief issue. Recently, we are seeing one of the people, he dealing with the complicated grief, very, very, so I think I want to learn more about how we can help to solve that loss and grief issue. So I want an expert opinion for those. And I want Nala to ask what is her opinion in dealing with the loss and grief issue of loss of identity and loss of rights as a nationality or something like that.
Thank you, Wawa. And Nala, please just come in a second. But this is something which has been at the heart of some of our PallCHASE webinars. And I'm sure this is something we're going to come back to again because it's so important. But Nala, your point of view would be really helpful there. And Eric, thank you. You've written something in the chat also on this issue. Yeah, Nala.
Yeah, I think having all these losses, moving, losing your house, moving, losing people, it affects you psychologically. It affects even the meaning of life for you. It affects you spiritually. The first point, I think, is recognizing this loss. We as palliative care providers, we should train more people to how to help the people. For example, we have been training social workers and psychologists in grief and supporting psychological support and caring for the self. And I think we have to make a benefit of specialized people and to train more people to help. So these social workers and psychologists, they were very enthusiastic about how to support patients in multiple losses, to identify them, what is the meaning of life after all these losses. And I think so there's Professor Eric is also going to feed us. Yes.
Thank you,
training, supporting, acknowledging these and listening to them, I think. Thank you.
Thank you. And we've had some presentations in previous sessions about some very specific programs from Ukraine and also from Gaza. Eric, thank you for what you put in the chat. And Jim, thank you for reminding us of the cultural context of any intervention. Eric, is there anything you want to add?
Yes, just to say that it has really been overwhelming with all of the losses, but some of the things that keeps us going are opportunities to share, like what we have now. Understanding that it's not just happening to you, and also having solutions the way others are coping in various places. Those are some of the things that have actually kept us going. But like I said, sometimes we find time off work just to get somewhere, look at nature, and that has been relieving. I've also had the opportunity to study currently on a master's program where I had to deal with death, dying, and bereavement. And that has also been very useful to me. It has helped me as a person because this has been one of the years that I have had, last year, of course, with multiple losses in my family and equally at my job site. But because of what I gained from palliative care, it's helping me to move on. So it's truly very challenging with all of these losses all around. Sometimes we truly just cry with the patients, but we have to keep going. We cry, we wipe our tears, we support them, and we move on. We are saying that with PallCHASE and other organizations, if we have more forum, so that more opportunities, so that we can be able to build resilience and continue the good work, I think it's useful. Otherwise, some people can fully break. I see some workers in Cameroon who truly said, no, we are not continuing with palliative care and all of that, just because they feel that the support has not really been there. The government is not supporting, the institution is not giving in as much, the patients are there with the load and you can think of it. But opportunities like what we now can keep us going. Thank you.
Thank you, Eric. And in a small way, we're standing together with you today and at least hearing what you have to say. And we've already had a suggestion that we look a bit further another time at grief and loss and meaning of life and bereavement. I want to bring in our panelists before we run out of time. Then please come, Dr. Thin, please come and just comment on what you've been hearing and with your kind of development perspective too and partnerships perspective, any comments you would like to make. Thank you so much for being on our panel.
Thank you so much, Moira, and good afternoon, good evening to everyone who has joined the session today. It's good to see you all. So I have observed many similarities across Nala's, Eric, and Wawa's presentation. And so because Wawa has nicely kind of summarized different forms of conflict, but in my opinion, for Sudan, Cameroon, and Myanmar, Ukraine, Syria, everywhere, we are now faced with, unthinkable and undescribable, overwhelming form of man-made conflict, and that has sadly followed the world's, worst pandemic in the world after 2 years. So that has a significant impact on the people with cancers and people who are approaching their end of life. So particularly, we have covered about difficulty in access to essential medicines which are required for palliative care. We have heard about difficulty in access in terms of transport or referral of patients from one place to another because of the conflict and the war and the shooting outs, and the safety of the healthcare workers as well as safety of the patients. And secondly, we have described about the lack of infrastructure, such as the shortage of radiotherapy machines and the electricity and human resources. Moira understands that palliative care in Myanmar is very young specialty. Wawa has been really trying very hard to kick it off the ground, and unfortunately pandemic hit, and that has followed with a coup in February 2021. Although this has although we might not see significant or very patchy effect in urban areas such as Rangoon and Mandalay, people in other parts of the country, such as remote parts, ethnic areas, and in Sagaing and Magui, Irrawaddy Delta, Danindai Division, how can these people come to Yangon when there are conflict? So there are a whole load of issues. Where are these cancer patients gone to? Have they gone and traveled to see the specialists in Thailand, India, or other neighboring countries? That means that more out-of-pocket expenditure and heading towards deeper poverty. So there are whole loads of issues. But the good thing to look at the solutions that I have heard across 3 presentations are that, number one, seeking to innovative ways of using technology to consult patients when physical contacts are not possible. Although it is not ideal, we have pivoted to using applications like Ziwaka in Myanmar, and for Eric, he used WhatsApp, Zoom, and etc., which is a fantastic. The theory of survival of the fittest. We are finding our ways to conquer the unbeatable problems as best as we can. So that is one. Second is that we have to keep advocating the width and the depth of the problems, such as the inaccessibility to medications, by voicing out to humanitarian partners and UN agencies and the development partners how they will find alternative solutions to bring these medicines to most vulnerable people where it is most needed. And third is the continued working with health partnership communities, such as the friends across the globe, so that we can share our resources and training, so that we are not alone in this, and continue training the junior doctors, junior nurses, and junior healthcare workers, spreading the basic education about dealing palliative and the psychological support, and supporting the end-of-life patients. And lastly, I would like to emphasize that in this field, especially the palliative care, in the conflict setting, we need more insight into this, how we will overcome these problems. So I think research is the most important thing, and it is easier to set, but there will be tremendous challenges in developing a research, because conflict itself is very dangerous, and palliative is also a very niche specialty, although the need is very wide and great, but we need to do this research so that the people across the globe where they are faced with this loss and griefs could be managed with better quality services. Thank you.
Thank you so much for those very wise comments. Please do be aware we have groups within PallCHASE. We have a research group, we have an education group, advocacy groups, and I've forgotten what the other one, please help me, a communications group. Please do join PallCHASE. We'll be giving you instructions in just a moment how to do that and get engaged and get involved. I've just been doing some needs assessment in a rural area, and you're so right, research is needed, and there is some coming, and there's more to be done. Megan, please, as our final panelist, would you like to give some comments?
Thank you very much, Moira. And it's been so inspiring to hear from all of you. And I really want to just echo the words of many of the PallCHASE exec that this is incredible work. And we just are so glad that we're able to hear about it, that you took the time to share it with us, and that we can share it with more people, which is so important. And I hope strengthens you and your feelings today. I want to just bring a few highlights, and Dr. Thin beautifully summarized everything. And I think I was almost reading my notes as she was summarizing. It was the same ideas that I had. I think I will just say three things really stood out for me, 3 words. And I wonder if these words might be words that some of us take away with us today. Connections, partnerships, and solutions. And I think this is part of the connections idea, that we're connecting here today. We're all connected, and that feeling of connection and the experience of it is so important, I think, in this work, because it threatens to isolate us, but we have to be connected to feel supported and to know that we're doing the right thing. And there's so much passionate, vision for this. I think of Eric just saying, I have to do this. This is what I must do to keep this going. And, I had a student very recently who did a systematic review with me. So she was new to palliative care, and she said, Dr. Doherty, like, everyone is just so creative and they just make it work in palliative care. She had reviewed all these different programs, and that is what we are. We are so connected and creative. We have so many partnerships as our second word. Dr. Wawa shared with us all the different things in Myanmar, how there's partnerships with APHN and ASCO, all these groups. And it's really that around the world that we all connect and we find those others who can support us. Eric mentioned MSF in Cameroon as well, although not as much now, Mercy Ships, but those partnerships are so key. We can never do it if we're just alone. And then solutions. And I know Dr. Thin said we don't know all the solutions. We don't know exactly the best way to always do palliative care. We need more research. But I also think we do know some of the key practices. As people who know some palliative care, all of us have a sense of what our patients need. They need home visits, they need oral morphine, all these things that we really know are the core and the heart of palliative care. And those don't really change even depending on the setting. So those are the 3 words and final thoughts that I just wanted to share with everyone today. And I have so much respect and acknowledgement for all that you're doing. And I just want to thank all of our speakers for an incredible session.
And despite the fact there's many more questions we could talk about, we are coming to the end of this workshop today. There will be another webinar, sorry, not workshop, webinar tomorrow with the same speakers. So if you really try something and you want to listen again and take that in and ask some more questions, please join us again if your time zone allows. Please do also sign up to PallCHASE. I think we're going to have something on screen with even a QR code to tell us how we can do that. Thank you to Erin or to Megan who's doing that. And do get involved. We're a young organisation. We're particularly keen to build our links in the humanitarian sector. So if you're working with colleagues, please invite them to join us. And there is also an upcoming workshop at the Indian Association for Palliative Care in a few weeks' time, where we'll be taking forward an existing concept to have a guide for palliative care in humanitarian settings. And that may answer some of the things that have been talked here. We want to signpost good practice, signpost things that have gone well, and give practical examples from specific settings, just to give some support for people and showcase some of the excellent work. We'll also have the videos from today on our YouTube channel, and will be linked in through Twitter and through the website. I think if there's anything else I've forgotten, team, please put it in the chat there. I was going to show you where we're. Are you able to let me do that? If I can do that. Let me see. Does that work for you? Can see where we're from? I'm sorry, I'm not managing it as well as I would like. How's that?
Yes, we can see, Moira. That's really nice. So
that was just a try to use something called Mentimeter and to see where you're all joining from. That's wonderful. Thank you for that. I think there may even been a couple of others who weren't able to join, and we'll keep a record of that. Great. So thank you particularly to Drs. Nata and Wawa and to Eric. You have really inspired us, challenged us, reminded us that we sometimes can be overwhelmed in all of our settings. What is it that's under our control? What can we do in that setting? How can we make partnerships and connections? And how can we, as a palliative care family, humanitarian family, share and support one another? And how do we provide the evidence and the research to do this well? And lastly, advocate for more and better care. As we know, palliative care is actually a very large part of people's care needs in these settings, living with chronic illness. And yet it does only have a small focus much of the time. Thank you to everybody, and thank you for being so really use the chat. I want to thank particularly those joining. I think we have fellows from we've definitely got diploma students joining from Gaza who are doing this as part of their diploma. They're joining and interacting, and I've seen the interactions. And then we also have fellows from Joan from
the Elizabeth Kubler-Ross Foundation.
That's it.
The
Thank you
APH
so much.
Lovely. South Asia Partnership and Fellowship.
Great. So that is just saying thank you, and see some of you and